in mitral regurgitation for about 30 years. The physical exam first attracted me to it. And you can see here that there is a leak in the mitral valve. Dr. Lax, there's a stretch on the myocardium, but also a huge stretch on the left atrium. And interestingly, the ventricle ejects into the low-pressure left atrium, so that there is a sort of a false sense of security with the ejection fraction in terms of what's going on with the myocardium. Did this, Mark Starling and Rick Walsh and Bob O'Rourke and I, 1985. High-fidelity pressure monitoring in a patient with simultaneous biplane cine angiography, showing the left ventricular pressure rise, aortic valve opening here, simultaneous aortic pressure, Tmax, minimum volume, aortic dicrotic notch, all in a very nice tight space here. No difference between minimum volume and end ejection. In mitral regurgitation, here is the volume of the ventricle starting to decrease even before aortic valve opens, so there's no isovolumic pressure generation. And as you can see at the end of systole, there's a great disparity between minimum volume and end ejection, so that the end systolic pressure volume relationship also becomes a problem, as it actually was with the right ventricle when we showed it. A nice example from Blaise Carabello of what we're looking at in terms of pressure versus volume overload is here a dog with mitral regurgitation and a dog with aortic constriction after about 4 weeks. And here you see the rise in the volume decrease before aortic valve opens, because remember, half of this stroke volume, or 40% of it, may be going backwards into the left atrium. And you can see the difference. There's no increase in pressure. Here, there is actually volume decline, a decrease in volume as pressure is declining. So you see that there is a pure stretch on the myocardium with mitral regurgitation. And now this is where what I was interested in, because very early on, because when you call upon the Starling reserve and the heart stretches, once you hit that point, like in exercise, Dr. Joyner, what happens? The adrenergic nervous system kicks in. Well, Mark Starling, who was my mentor at UTSA, Blaise Carabello, I'll tell you about Jeff's and our studies, very early on in the human and the dog with isolated MR, that there is a recruitment of preload reserve that is quickly followed by increased adrenergic drive, and it's huge, even in mild mitral regurgitation. What we did with Jeff was we did the dog very early on and did spinal stellate ganglion stimulation with Dr. Armour. And there we looked at the release of norepinephrine into the interstitial fluid space using cardiac microdialysis. And clearly there was an increase in ISF norepinephrine early in the process, but with stellate ganglion stimulation, it went way up, way up. And it was blocked by beta-adrenergic receptor blockade chronic treatment. I also have to add that we also looked at bradykinin. I hear bradykinin mentioned all the time. With a volume overload in the rat and the dog, interstitial fluid bradykinin and the kallikrein-kinin system is upregulated in the heart. Now this is, we do a lot of magnetic resonance imaging in patients with our SCORE grant that we had between 2004 and 2010. And here you can see the nice elliptical shape of the normal ventricle ejecting again to the football. Look at this. This is a patient, and you can see this ejection fraction is 60%. But look at how the heart has remodeled, and especially the left atrium. Look at how huge that is. And I'll show you later, we have biopsies from these patients with a microarray demonstrating that at the tissue level, the beta-adrenergic signaling system, G-protein coupled signaling, all the genes are upregulated in these hearts. Now, the challenges of volume overload are currently What's the best timing for surgical intervention? And what is the best therapy to protect the myocardium while you're running around? Actually, the heart is running a marathon with every beat because it's called upon to increase more volume in the sense that there's 40% going backwards. Now, this just came out, and it's from Hartzell Schaff, and he's done a lot of work at the Mayo with mitral regurgitation. And look at the title. Left ventricular dysfunction after mitral valve repair. The fallacy of the normal preoperative myocardial function. He studied 1,700 patients, and 20% of them who came to surgery under guidelines, LVEF greater than 60%, and systolic dimension less than 40 millimeters, 20% had a decrease in ejection fraction, and half of those went below 50%. Class 1 LV function thresholds, the greater than 60% and less than 40%, were set on previous studies of just on postoperative survival. And there was less assessment of postoperative LV function. Now, why does the LVEF go down after surgery? Well, this is a review. If you want to read it, it was in the American Journal of Medical Science. We just published it, and it's entitled The Multiple Mechanistic Faces of Volume Overload, of which, or surrounding the increase in adrenergic drive that is really impressive throughout the whole course. And you know, Dr. Zipes, I wonder how many of your patients who didn't respond may have had some mitral regurgitation or not. I just thought that when I saw, and I'd like to talk to you about it after at the break. So we have identified in the dog and the rat, it's really interesting. The fistula in the rat and the MR in the dog are exactly the same because the fistula ejects into the low pressure AV shunt and the MR ejects into the low pressure left atrium. And we have sort of an intermediate phase, a compensated phase, and a 14 to 15 week quote unquote decompensated phase, although the ejection fraction is still normal. And interestingly, at this stage, Pam Lucchese repaired the fistula and systolic function decreased afterwards, just like we see in the humans. Now, I'm going to take you from the extracellular matrix, which you saw with Dr. Zipes, with scanning electron microscopy. This is from Dr. Robinson years ago. From what's happening extracellularly to what's happening inside the cardiomyocyte with respect to the cytoskeleton and the mitochondria, in particular Desmond and its attachments and holding together the whole cardiac cytoskeleton. We used the dog model of mitral regurgitation under fluoroscopy going in with a urologic grasping forceps. Blaise Carabello taught us how to do it. And here's end diastole and systole at baseline. And 4 months later, this is the model that Jeff and Drew and Bob Foreman and I worked with to do all the microdialysis and documenting the upregulation of the adrenergic nervous system. But again, you see the thinning of the wall, sort of an outstripping of the mass to volume ratio. You have a big volume and a hypertrophy response that's not very robust. And Dr. Zipes, this is what we see. We see elongation of cardiomyocytes and a loss of the interstitial collagen. We see it in the rat, we've seen it in the human, we see it in the mouse, and we see it in the dog. The pure stretch of volume overload without a pressure stimulus turns on a signal. Number one, with the stretch, and I'm going to show you where the increase in adrenergic drive comes in. So this is basically with ACE inhibitors, it doesn't help at all. We've also published with AT1 receptor blockade in Journal of American College of Cardiology, where it didn't get better. RAS blockade is antifibrotic. Here you have a problem with actually collagen being broken down. And we asked the question, and here, by picric acid Sirius red, you see the decrease in interstitial collagen, the decrease actually also in hydroxyproline, which is a marker of collagen synthesis. And again, here's a nice example of the dog, baseline and MR. But we did a microarray. We got a biopsy before inducing MR and got the tissue 4 months later. And interestingly, what we saw was that there was a marked downregulation of all of the genes of ECM structure. Decorin, which connects collagen fibrils and gives the collagen fibrils their tensile strength. Fibrillin, the fibrillin 1 gene, the gene that's abnormal in Marfan syndrome. And all of these other genes of the extracellular collagen, whether you look at the mouse, the rat, the dog, or the human, does not increase in the setting of a marked decrease in interstitial collagen. And also genes related to synthesis, MMP1 and 9 were up, and all the major players, the TGF-beta binding protein, and we documented this with protein analysis, all of these were downregulated. Why? Why does this happen even though, if you look at these hearts, the renin-angiotensin system is also upregulated? Why does the fibroblast fail to produce collagen in the pure volume overload of mitral regurgitation? Well, we didn't have enough money to study this in the dog, so we started studying it in the rat. And what we found were some interesting things. Number one, there's increased cardiomyocyte oxidative stress. Desmond is broken down. It's kind of like delayed onset muscle soreness that you see in athletes after Desmond's broken down in the skeletal muscle. There's an increase in myocardial lipids, and there's mitochondrial damage and disorganization. We also see impressive increase in oxidative stress within cardiomyocytes, especially xanthine oxidase, and impressive evidence here, normal, with hematoxylin and eosin, a marked decrease in myofibrils, especially troponin and other components of the cardiomyocyte, but there's extensive myofibrillar degeneration. And nitrotyrosine staining here, and this is the immunoabsorbed antibody, but this is really impressive. This here is autofluorescence due to, which we saw impressive examples of, due to lipofuscin accumulation, which is a marker of increased oxidative stress. Again, here is the human. This is what we see, well-preserved ejection fraction, but as you saw in the human, a marked increase in oxidative stress. And we saw this remodeling. The thing that got me really interested in this was if you go into the left lateral decubitus position and you feel for the PMI in these patients is really impressive. It's large. And what happens is that you, even in mild mitral regurgitation, as opposed to the elliptical shape of the ventricle here, there is a spherical apical remodeling, and also at end systole, so that the dimensions that you measure at the base of the heart actually belie the marked increase in end diastolic and end systolic volumes. And since I saw Dr. Joyner here, I decided to show this slide of when we looked at a volume overload from a marathon runner here, and this is a normal heart, compared to the mitral regurgitation heart. What you see in a marathon runner is, if you can imagine my fingers getting longer, and it remains elliptical, as opposed to the length of the ventricle in these patients with just moderate MR and asymptomatic. The length of the ventricle didn't increase, and you had a more spherical, I call it a Gothic versus a Romanesque architectural change. Now, I have to go back to the rat. So I'm going to go back and forth, Dr. Lax, I'm going to go back and forth because there were questions that are raised at the bedside that we had to go back and answer it with the rat. But you remember I told you that we identified these stages of compensated and decompensated, but still with a normal ejection fraction. What's really interesting is Dr. Dalla looked at beta receptor density in these animals at all those stages. And there's a significant increase in beta-1 receptor density, while beta-2 receptor density was unchanged. And basal adenylate cyclase and both isoproterenol and forskolin-stimulated activity increased. And very interestingly, if you gave these animals with these dilated ventricles at 15 weeks, either dobutamine or isoproterenol, in vivo, they had a marked increase in contractility. So the adaptive change in volume overload is increased adrenergic drive, but also increased beta receptor density, even though the hearts may be markedly dilated and, in a sense, failing. And in our patients, where we got the biopsies from normals, from a normal registry, and our patients, we found cyclic AMP signaling, G-protein coupled signaling, all of these genes significantly upregulated here, as you can see, especially G-protein coupled signaling here. They're markedly upregulated. So you see in the human and in the rat and in the dog, the compensatory mechanism is increased adrenergic drive after just a little bit of dilatation. And also, when we take out fibroblasts from these rats at 12 weeks, we see increased oxidative stress inside the fibroblasts. And here's an example of our purity. And alpha smooth muscle actin is in red, and you can barely see it because even at 12 weeks, we don't see any myofibroblasts. And also, this is the key, we see marked increase in cyclic AMP in red. Here are the sham, and here are the fibroblasts from a rat of 12 weeks duration of ACF, and a marked decrease in interstitial collagen. And it's interesting that Paul Insel at San Diego is actually looking at cyclic AMP elevating agents and adenylate cyclase overexpression promote an antifibrotic phenotype in pulmonary fibroblasts. So that, as you can see, the increased adrenergic drive has something to do, or probably has something to do, with the antifibrotic state. And in addition, it turns on autophagy within the cardiac fibroblasts. So as you can see here, a normal cardiac fibroblast by transmission electron microscopy, and here is a fibroblast taken from a 12-week ACF animal. The LC32, the LC31 ratio is, that's procollagen. The procollagen in these fibroblasts is markedly decreased, right here, quantitated. The LC32 to LC31 ratio is increased, and message for collagen is unchanged, even though there's increased adrenergic drive, which is usually associated with fibrosis, and the renin-angiotensin system. And what we're proposing is that this increased autophagy, when you take a fibroblast and give it rapamycin to turn on autophagy, that the procollagen is actually degraded within the fibroblast. And when you give wortmannin, which inhibits autophagy, the procollagen increases, which is exactly what we saw when we took the fibroblasts out of the animals with ACF. So we're proposing a new paradigm here of increased adrenergic drive. Also, we see a lot of mast cells in the human, the dog, and the rat, and a lot of mast cell degranulation for which there is a connection. An increase in ROS, increased cyclic AMP, decreased collagen formation and degradation by autophagy, and increased MMP production. And indeed, when we gave a beta-1 receptor blocker in the dog, we actually were able to preserve collagen and improve cardiomyocyte function. Now, this is really interesting because this came out from Min Poo at Wake Forest, where he gave the the cumulative survival in rats with mitral regurgitation, he gave them carvedilol, and it killed them. Now, I talked to Paul Simpson about this, and you know, when you block non-selectively beta 1, beta 2, beta 3, and alpha blocking, you really take away an important, probably an extremely important mechanism of compensation. Not to mention that we have demonstrated in our dog model that the beta 2 activation is protective and protects against apoptosis. And with beta 1 receptor blockade, Emily Tsai at Temple University, we just published that the beta 3 receptor is upregulated fourfold in the dog, which is also a cardioprotective beta receptor. And the alpha receptor is also cardioprotective and a positive inotropic agent. So I think that, again, I wonder whether neural stimulation may have something to do with which beta receptor blocker you're using. I don't know. These are things that just popped into my head when I was looking at your proposal and at what stage the heart failure is and what other comorbidities there might be. So we're at this point right now where we just published a phase 2b clinical trial that demonstrated improvement in systolic function over 2 years of follow-up, doing a rate of progression analysis, imaging the patients every 6 months for 2 years. And the treated patients had an increase in ejection fraction and an increase in diastolic function. The untreated patients had a decrease. Also, 6 out of 20 patients had to go to surgery in the untreated, and only 1 out of 20 had to go to surgery in the treated. And we had a very nice editorial from Dr. Carabello as a result of that. We saw the same thing in the dogs in terms of improvement in fractional shortening, just like Blaze did, and an improvement in calcium transients in dogs treated chronically with beta receptor blockade. In addition, Blaze showed the same thing and also an improvement in myofibrillar density of the cardiomyocytes. And then finally, this is a great editorial, but it talks about lipid toxicity and the accumulation of lipids inside the myocardium, which we see quite impressively. And we see a decrease in fatty acid oxidation with mitochondrial dysfunction that would result in a diversion of lipid storage pools to intermediate toxic species like diacylglycerols, and in particular, ceramide. And indeed, in our gene array, all of these genes related to fatty acid metabolism, fatty acid oxidation, were significantly downregulated in our human heart. We saw the same thing in the rat heart, and this is a normal transmission electron micrograph. Nice mitochondria, sausage shape, very close to the myofibrils. Nice Z-line here, okay? Nice I-band. You notice it there. There's perinuclear mitochondria, but this is what we see in the human. Lipofuscin accumulation in a 35-year-old, which is markedly abnormal. It's usually the aging pigment of the heart. A lot of triglyceride droplets, a lot. And just a total disorganization of the sarcomeric structure. The I-band is blunted. Many ultrastructural abnormalities. And this is a patient, in fact, all of our patients had EFs greater than 60%. Another example of even in the subsarcolemmal mitochondria, breakdown of the mitochondria, and here triglyceride, and here mitophagy going on, breakdown of mitochondria, and a lot of triglyceride, and this is probably an autophagic vacuole. Some of them are autophagic vacuoles. The grayer ones are triglyceride accumulation. And then also, looking at mitochondria from a 12-week ACF mitochondria, you see an increase in ceramide, which also, I think, is related to the increase in adrenergic drive, such that when we start looking at the transmission electron microscopy in a normal rat, beautiful eye band, nice sausage-shaped mitochondria, this is what we start seeing. Tremendous breakdown in the mitochondria, some mitophagy, loss of myofibrillar density, loss of the eye band, and going a little bit further, in the human, we see this. We see a breakdown in Desmond and aggregates of Desmond in the human heart. Again, this is in a patient with an ejection fraction of 65%. And this is Desmond here. Here's the intercalated disc. This is the Desmond along the Z disc at the, outlining each sarcomere. And you can see a total breakdown in between the intercalated discs of Desmond in these human hearts, which we also just published. Dr. Zucker was the editor on this, and here is Desmond in the rat heart, and in areas that we can see in the rat heart, total breakdown of Desmond in these hearts, probably due to increased oxidative stress and activation of proteases within the myocardium. Again, here, the sausage-shaped mitochondria losing all of their architecture and breakdown of myofibrils. And this rat has a normal ejection fraction. So in summary, we think that in the fibroblast, at least, we have this new paradigm of, and in fact, increased ROS, all of us who are over 60 know what happens to our skin. We lose its structural integrity. Well, the fibroblasts in aging skin have increased autophagy, breakdown of procollagen, MMP activation, and they do not produce collagen or elastin. So that I think that we can really link this back to increased adrenergic drive. In the myocyte, there is a dysfunction of calcium homeostasis, I think lipotoxicity, and Desmond degradation, resulting in cardiomyocyte remodeling. And when you start breaking down mitochondria like you do there are tremendous. Their volume is 40% of the cardiomyocyte. Can you imagine if they start producing ROS, which we've actually shown in the recent paper that we published in the American Journal of Physiology? So that's it. This is our laboratory of graduate students. These two guys are in the clinician scientist training track. The Center for Free Radical Biology with Victor and Scott. It was all funded by our SCORE and now R01s. The Auburn School of Engineering, the Vet School, the CV Surgery with David McGiffin, Cardiovascular MRI with Himanshu and Steve, the Department of Biostatistics who thought of this rate of progression analysis, still working with Kareem at Temple University, now with Cell and Integrative Biology, and now with Carlos Ferrario at Wake Forest, looking at the role of proteases such as chymase in this remodeling process. Thank you.